Hi there, welcome. This is Bhante and Rakkhita Samanera, also known as Brother Ben. So today we're going to be working on borderline personality disorder. Going to be looking at the book by Sperry. It's the Handbook of Diagnosis and Treatment of the DSM-IV personality disorders. Quick disclaimer, I'm not claiming to be a licensed health professional, and I'm not claiming to be a highly qualified doctor of psychology or so on. I have a diploma in Buddhist psychotherapy and counseling, gained in Singapore. I have also experience of many meditation interviews, somewhere in the region of about 7,000 interviews during my early time in monkhood. So we are looking into the borderline personality disorder. It helps us to process many of the people that we've met during our time in life. I've encountered people with borderline personality disorder in many different roles and guises, and this helps to understand and to be able to categorize those experiences as well. So without further ado, let's go on straight in. I'll be working through chapter 4 of Len's book, which goes through each of the DSM criteria one by one. Borderline personality disorder. The borderline personality disorder has captured the attention of the mental health community, as has no other diagnostic entity. Not only are an increasing number of patients with borderline personality disorders showing up in the caseloads of mental health clinicians, but many clinicians are convinced that they are largely untreatable. The borderline personality disorder has been dubbed one of the most prevalent neurotic personalities of our times, Len Sperry, 1991. And more books, articles, and research studies on this disorder have been published in the past 5 years than any other psychiatric disorder. Workshops, seminars, and the subject of borderline pathology are ever present. Previously, the borderline personality was called pseudoneurotic schizophrenia, schizophrenic character, ambulatory schizophrenia, or latent schizophrenia. Efforts to understand this condition, which seemed to be on the border of neurosis and psychosis, have occupied many psychoanalytic theorists and researchers, and more recently, descriptive and phenomenological researchers, largely because of the increasing interest in and literature on this disorder. The borderline personality disorder was added to the DSM-III. Prior to that, borderline patients often were diagnosed in the DSM-II category of schizophrenia latent type. But dissatisfaction with the failure of DSM-II, DSM-IIR episodes prompted the inclusion of transient, stress-related, paranoid ideation of severe dissociative symptoms as a criterion in DSM-IV. So let's have a look at the difference between the personality style and personality disorder. So in the personality style, they tend to experience passionate, focused attachments in all relationships. Nothing in the relationship is taken lightly. They're emotionally active and reactive. They show their feelings and put their hearts into everything. On the disorder side, A pattern of unstable and intense relationships noted by alternating between extremes of over-idealization and devaluation. Impulsive in at least two areas that are potentially self-damaging. For example, spending, sex, substance abuse, shoplifting, reckless driving, binge eating, suicidal threats, gestures, or behavior. They tend to be uninhibited. This is on the personality side. Tend to be uninhibited, spontaneous, fun-loving, and undaunted by risk. They tend to be creative, lively, busy, and engaging individuals. They show initiative and can stir others to activity. They're imaginative and curious. They are willing to experience and experiment with other roles, cultures, and value systems. They regularly tend to become deeply involved in a romantic relationship with one person. Back to personality disorder. Affective instability, marked by shifts from baseline mood to depression, irritability, or anxiety, usually lasting a few hours and only rarely more than a few days. Inappropriate, intense anger or lack of control of anger. For example, frequent displays of temper, constant anger, recurrent physical fights, chronic feelings of emptiness or boredom. Marked and persistent identity disturbance, marked by uncertainty. About at least two of the following: self-image, sexual orientation, long-term goals or career choice, type of friends desired, and preferred values. There are frantic efforts to avoid real or imagined abandonment. There remains concern about the designation of borderline. Is it a specific personality disorder, or is it a dimension of personality, or a personality organization? This was Kernberg, 1984. Or a spectrum disorder, Meissner, 1988 it was. If the designation of borderline refers to a continuum, then all the personality disorders in clusters A and B could be considered borderline conditions. Estimates are that approximately 2% of the general population meet the criteria for this disorder, and that about 10% of outpatients and 20% of psychiatric have the disorder. Finally, clinical populations with personality disorders meet the criteria for borderline personality disorder. This chapter describes the characteristic features of this disorder and its related personality style. 5 different clinical formulations and psychological assessment indicators are highlighted. Also described are a variety of treatment approaches, modalities, and intervention strategies. Characteristics of the borderline personality style and disorder. The borderline personality is characterized by the following behavior and interpersonal, cognitive, and emotional styles. Behaviorally, borderlines are characterized by physically self-damaging acts such as suicidal gestures, self-mutilation, or the provocation of fights. Their social and occupational accomplishments are often less than their intelligence and ability warrant. Of all the personality disorders, these patients are most likely to exhibit irregularities of circadian rhythms, especially of the sleep-wake cycle. Thus, chronic insomnia is a common complaint. Interpersonally, borderlines are characterized by their paradoxical instability. That is, they fluctuate quickly between idealizing and clinging to another individual and devaluing and opposing that individual. They are sensitive to rejection and experience abandonment depression following the slightest of stressors. Millen, 1981, considers separation anxiety a primary motivator of this personality disorder. These individuals develop interpersonal relationships rather quickly and intensely, and yet their social adaptiveness is superficial. They are extraordinarily intolerant of being alone, and they go to great lengths to seek out the company of others, whether in indiscriminate sexual affairs, late-night telephone calls to relatives and recent acquaintances, or late-night visits to hospital emergency rooms with a host of vague medical or psychiatric complaints. Their cognitive style is described as inflexible and impulsive by Millen, 1981. Their inflexibility is characterized by rigid abstractions that easily lead to grandiose, idealized perceptions of others, not as real people, but as the personification of all good or all bad. They reason by analogy from the past and have difficulty in reasoning logically and learning from past experiences and relationships, because they have an external locus of control. Borderlines usually blame others when things go wrong. By accepting responsibility for their own incompetence, they believe they would feel even more powerless to change circumstances. Accordingly, their emotions fluctuate between hope and despair because they believe that external circumstances are well beyond their control. Schulman, 1982. Their cognitive style is also marked by impulsivity, and just as they vacillate between idealization and devaluation of others, their thoughts shift from one extreme to another. I like people. No, I don't like them. Having goals is good. No, it's not. I need to get my life together. No, I can't. It's hopeless. The inflexibility and impulsivity complicate the process of identity formation. Their uncertainty about self-image, gender identity, goals, values, and career choices reflects this impulsive and flexible stance. Gerald Adler, 1985, suggests that borderlines have an underdeveloped evocative memory, so that they find it difficult to recall images and feeling states that could structure and soothe them in times of turmoil. Their inflexibility and impulsivity are further noted in their tendency toward splitting. Splitting is the inability to synthesize contradictory qualities, such that the individual views others as all good or all bad, and uses projective identification, that is, attributes his or her own negative or dangerous feelings to others. Their cognitive style is further characterized by an inability to tolerate frustration. Finally, micropsychotic episodes can be noted when these individuals are under a great deal of stress. These are ill-defined, strange thought processes, especially noted in response to unstructured rather than structured situations, and may take the form of derealization, depersonalization, intense rage reactions, unusual reactions to drugs, and intense, brief, paranoid episodes. Because of their difficulty in focusing their attention and the subsequent loss of relevant data, borderlines also have a diminished capacity to process information. The emotional style of individuals is characterized by marked mood shifts from a normal or euthymic mood to a dysphoric mood. In addition, inappropriate and an intense anger and rage may be easily triggered. At the other extreme are feelings of emptiness, a deep void, or boredom. The following case examples further illustrate the difference between the borderline personality disorder, Mr. J, and the borderline personality stance, Janice P. Case study. Borderline personality disorder. Mr. J is a 31-year-old unemployed man who was referred to the hospital emergency room by his therapist at a community mental health center, after 2 days of sustained suicidal gestures. He appeared to function adequately until his senior year in high school, when he became preoccupied with transcendental meditation. He had considerable difficulty with concentration during his first semester of college and seemed to focus most of his energy on finding a spiritual guru. At times, massive anxiety and feelings of emptiness swept over him, which he found would suddenly vanish if he lightly cut his wrist, enough to draw blood. He had been in treatment with his current therapist for 18 months and had become increasingly hostile and demanding as a patient, whereas earlier he had been quite captivated by his therapist's empathy and intuitive sense. Lately, his life seemed to center on these twice-weekly therapy sessions. Mr. J's most recent suicidal thoughts followed the therapist's disclosure that he was moving out of the area. Case study. Borderline personality style. Janice P., 29-year-old graduate student in Oriental literature. She had completed her undergraduate degree at university in business and management with honors, and had planned on starting her MBA degree that fall. A summer tour of Japan and China dramatically changed her life. She fell in love with the Orient. The people, the food, the customs, the ambience, but especially with a literature professor whom she met at a Tokyo university. She fell madly in love with him the first time she saw him at a chance meeting, and spent the 2 weeks before her flight back to the United States totally engrossed with his poetry, his stories, and his life. He was married, but his wife was away on a vacation. Janice was conflicted about returning home, even though the professor had broken off the relationship. She entreated him to leave his wife and was crushed that he would not do so. She returned to the university with an ardent desire to immerse herself in the study of Oriental literature. She returned to the university with an ardent desire to immerse herself in the study of Oriental literature. She had fantasies of going back to Tokyo as a visiting professor and working with the love of her life, with the goal of eventually having him all to herself. Even though she was doing well in her classes, she occasionally got in touch with the anger and hurt she had experienced that summer. Midway through her first semester in graduate school, she met an Oriental graduate student with whom she instantly fell in love. So, end of that case study. Now, the DSM-IV description and criteria. This table gives the DSM-IV description and criteria. Table 4.2, DSM-IV description and criteria for borderline personality disorder. Borderline personality disorder, a pervasive pattern of instability of interpersonal relationships, self-image, and affects, and marked impulsivity beginning by early adulthood and present in a variety of contexts, as indicated by 5 or more of the following. 1. Frantic efforts to avoid real or imagined abandonment. And a note here, do not include suicidal or self-mutilating behavior, which is covered in criterion number 5. Number 2, a pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation. 3. Identity disturbance, markedly and persistently unstable self-image or sense of self. Number 4, impulsivity in at least 2 areas that are potentially self-damaging. Example, spending, sex, substance abuse, reckless driving, binge eating. Note here, do not include suicidal or self-mutilating behavior, covered in criterion 5. Number 5, recurrent suicidal behavior, gestures or threats, or self-mutilating behavior. 6, affective instability due to a marked reactivity of mood. For example, intense episodic dysphoria, irritability, or anxiety, usually lasting a few hours and only rarely more than a few days. 7, chronic feelings of emptiness. 8, inappropriate, intense anger or difficulty controlling anger. For example, frequent displays of temper, constant anger, recurrent physical fights. 9, transient, stress-related, paranoid ideation or severe dissociative symptoms. This was reprinted with permission from the Diagnostic and Statistical Manual of Mental Disorders, the 4th edition, and it came out in 1994 by the American Psychiatric Association. Formulations of the borderline personality disorder, distinct. Psychodynamic formulations. Kernberg, 1975, targets the rapprochement subphase of Mahler's separation, individuation, developmental theory as the point of fixation. At this phase, children lack object constancy and thus cannot integrate the good and bad aspects of themselves or their mothers. Neither can they separate from their mothers, as they have yet to internalize a whole, soothing, internalized usage of the mother to sustain them during her physical absence. Kernberg points to a disturbance on the mother's emotional availability, rapprochement subphase, that is attributable to the constitutional excess of aggression in the child, to maternal problems with parenting, or to both. Masterson, 1976, and Masterson and Klein, 1990, implicate the rapprochement subphase, but emphasize the mother's behavior rather than the child's aggression. Typically, a borderline herself, the mother is deeply conflicted about her children's growing up and becoming their own persons. Thus, these children receive the message that if they grow up, something awful will happen to them or to their mothers, and that remaining dependent is the only way to maintain the maternal bond. This prospect of separation and individuation thus provokes abandonment depression in borderlines. No integration between a rewarding object unit and a withdrawing object unit is possible at this rapprochement subphase, accounting for the symptom of the borderline syndrome. Adler's 1985 understanding of borderline pathology is influenced by Kohut, 1971 and 1977, and Freiberg, 1969, and is based on a deficit rather than a conflict model, as with Kernberg. Inconsistency in maternal behavior and availability results in the borderline's failure to develop a holding nothing internalized object. This accounts for feelings of emptiness, depressive tendencies, and oral rage. Furthermore, the borderline individual has difficulty with summoning up internal images of the natural, nurturing figure in stressful situations. This cognitive deficit of evocative memory suggests a regression to a developmental age of between 8 and 18 months. These inadequate resources leave the borderline prone to fragmentation of the self, which is accompanied by profound emptiness called annihilation panic. Biosocial Formulation, Millen, 1981, views the borderline's lack of a clear, coherent sense of identity as central to the pathogenesis of this disorder. He believes that identity confusion or diffusion is the result of biopsychosocial factors that combine to impair a coherent sense of identity. Because of this central deficit, poorly coordinated actions, overmodulated affects, poorly controlled impulses, and a failure of consistent effort result. Thus, the borderline individual depends on others for protection and reassurance, and is hypersensitive to the loss or separation of these supports. On the basis of this research, Millen, 1981, and Millen and Everly, 1985, contend that the borderline syndrome is essentially a more severe and regressed variant of the dependent, histrionic, or passive-aggressive personality disorders. Biologically and temperamentally, borderline dependent individuals tend to exhibit a passive infantile pattern and to possess family histories marked by low energy levels. This pattern evokes parental warmth and overprotection, and they subsequently form strong attachments to and dependence on a single caregiver, which ultimately restricts their opportunity to learn the necessary skills for social independence and self-efficacy. This sets the stage for rejection by those on whom they have come to rely. Borderline histrionic individuals more often have family histories characterized by a high autonomic reactivity, and they exhibit hyper-responsiveness as a result of exposure to high levels of stimulation. Parental control tends to be exercised by contingently reinforcement patterns, and so these children feel competent and accepted only if their behavior is explicitly approved by others. And thus, they perform to secure support, attention, and nurturance. Borderline, passive, aggressive individuals tend to have exhibited difficult child temperaments, Thomas and Chess, 1977, as irritable, difficult to soothe infants. They likely received inconsistent responses from their caregivers, caring at times, harried, and frustrated at other times, and even withdrawing. They might have been products of broken homes and probably had a parent who modeled the erratic, vacillating, passive-aggressive behavior they display as adults. Cognitive behavioral formulations. According to Beck et al., 1990, 3 basic assumptions are noted in borderlines. I am powerless and vulnerable. I am inherently unacceptable. And the world is dangerous and malevolent. Because of their inherent belief that they are helpless in a hostile world without a source of security, they vacillate between autonomy and dependence without being able to rely on either. In addition, borderlines tend to display dichotomous thinking, the tendency to evaluate experiences in mutually exclusive categories, all good or all bad, success or failure, trustworthy or deceitful. The combination of dichotomous thinking and basic assumptions is the basis of borderline emotion and behavior, including acting out, self-destructive behaviors. Young, 1990, believes that maladaptive schemas develop during childhood and result in maladaptive behavior patterns that reinforce these schemas. Schemas such as abandonment loss, I'll be alone forever, no one would live with me or want to be close to me if they really got to know me, and emotional deprivation, no one is ever there to meet my needs, to be strong for me, to care for me. These are believed to be common early maladaptive schemas in borderlines. Marcia Linehan, 1987, describes a behavioral formulation of borderline pathology. She claims that a dysfunction of emotional regulation is the core feature of borderline pathology. resulting in a dramatic overreaction and impulsivity. This dysfunction is believed to be physiologically based and to be reinforced by significant others who discount their emotional experiences. Subsequently, borderline individuals develop little or no skill in emotion regulation. The combination of intense emotional responses, inadequate emotional regulation skills, impulsive behavior, and a disparaging self-attitude presages unrelenting crisis with which they are unable to cope effectively and over-reliance on others. From a different behavioral perspective, Turcat, 1990, believes that problem-solving deficits are the basis of borderline pathology. Interpersonal formulation. For Benjamin, 1993, persons with borderline personality disorders typically grew up in a family marked by a chaotic soap opera lifestyle. Without these dilemmas, life was experienced as hollow, boring, and empty. Whether these chaotic dramas were blatant or were sequestered from public view, the borderline to be played a central role, resulting in the impulsivity, mood instability, and unpredictability characteristic of life without constancy. The developmental histories of these individuals often included traumatic abandonment experiences, the isolation of which was typically marked by physical or sexual abuse. This abuse-laden aloneness became inexorably linked with the notion that the borderline to be was a bad person. These abuse experiences taught the individual to shift from idealization to devaluation, and to the extent that the sexual abuse experiences were painful, they set the stage for self-mutilation, as pleasure became confused with pain during such episodes. Family norms dictated that autonomy was bad, whereas dependency on and sympathetic misery with the family were good. In movements towards independence, competence, or happiness elicited self-sabotage. Furthermore, young borderline individuals learned from their families that misery, sickness, and debilitation draw forth love and concern from others. The adult consequence is that borderline disordered individuals believe that caregivers and lovers secretly love misery. In short, there is a morbid fear of abandonment and a wish for protective nurturance, particularly from a lover or caregiver. Initially, friendly dependence on the nurturer gives way to hostile control when the person fails to deliver enough. Borderline individuals believe that significant others secretly like dependency and neediness, and a vicious introject attacks the self in the face of any signs of success or happiness. Integrative Formulation. The following integrative formulation may be helpful in understanding how the borderline personality pattern is likely to have developed and to be maintained. Biologically, borderlines can be understood in terms of the three main subtypes: borderline dependent, borderline histrionic, and borderline passive-aggressive. The temperamental style of the borderline dependent type is that of the passive infantile pattern, Millen, 1981. Millen hypothesized that low autonomic nervous system reactivity plus an overprotective parenting style facilitates restrictive interpersonal skills and a clinging relational style. The histrionic subtype is more likely to have had a hyper-responsive infantile pattern. Thus, because of high autonomic nervous system reactivity and increased parental stimulation and expectations for performance, the borderline histrionic pattern was likely to result. Finally, the temperamental style of the passive-aggressive borderline was likely to have been the difficult child type, noted by Thomas and Chess, 1977. This pattern, together with parental inconsistency, marks the affective irritability of the borderline passive-aggressive personality. Psychologically, borderlines tend to view themselves, others, the world, and life's purpose in terms of the following themes. They view themselves by some variant of the theme, I don't know who I am or where I'm going. In short, their identity problems involve gender, career, loyalties, and values, while their self-esteem fluctuates with each thought or feeling about their self-identity. Borderlines tend to view their world with some variant of the theme, people are great. No, they are not. Having goals is good. No, it's not. Or, if life doesn't go my way, I can't tolerate it. As such, they are likely to conclude, therefore, keep all options open. Don't commit to anything. Reverse roles and vacillate in your thinking and feeling when under attack. The defensive operations utilized by the person with a borderline personality disorder are denial, splitting, primitive idealization, projective identification, omnipotence, and devaluation. Schulman, 1982. Socially, predictable patterns of parenting and environmental factors can be noted for the borderline personality disorder. The parenting style differs depending on the subtype. For example, in the dependent subtype, overprotectiveness characterize parenting, whereas in the histrionic subtype, a demanding parent style is more evident, and an inconsistent parenting style is noted in the passive-aggressive subtype. But because the borderline personality is a syndromal elaboration and deterioration of the less severe dependent histrionic or passive-aggressive personality disorders, the family of origin in the borderline subtypes of these disorders is likely to be much more dysfunctional, increasing the likelihood the child will have learned various self-defeating coping strategies. The parental injunction is likely to have been, if you grow up and leave me, bad things will happen to me, the parent. This borderline pattern is confirmed, reinforced, and perpetuated by the following individual and systems factors: diffuse identity, impulsive vacillation, and self-defeating coping strategies, leading to aggressive acting out, which leads to more chaos, which leads to the experience of depersonalization, include increased dysphoria, or self-mutilation to achieve some relief. This leads to further reconfirmation of beliefs about the self and the world, as well as reinforcement of the behavioral and interpersonal patterns. Sperry and Mossack, 1993. So let's go to table 4.3, characteristics of borderline personality disorder. 1, the behavioral appearance, and 2, the interpersonal behavior. So 1, behavioral appearance. The hemophiliacs of emotion, resentful, impulsive, acting out, helpless, dysphoric, empty, void, irregular circadian rhythms, sleep, wake, etc. Second one, paradoxical, idealizing and clinging versus devaluing and oppositional, rejection, sensitivity, abandonment, depression, separation anxiety as the prime motivator and role reversal. 3, the cognitive style, and 4, the feeling style. So the cognitive style, inflexible, rigid, abstracting, grandiosity and idealization, splitting, reasons by analogy, doesn't learn from experience, external loss of control, blaming, poorly developed evocative memory. So, and then the feeling style, extreme lability of mood and affect. 5, the parental injunction and environment, and 6, the biological temperament. So the parental injunction, if you grow up, bad things will happen to me, the parent, and overprotective or demanding or inconsistent parenting. The 6, the biological temperament, dependent type, passive infantile pattern, slow autonomic nervous system reactivity, parental overprotectiveness, restrictive interpersonal skills, and pleasing, clinging style, histrionic type, hyper-responsive infantile pattern, high automatic reactivity plus high parental stimulation and demand for child to perform, passive aggressive type, the difficult child, infantile pattern, plus affect of irritability, plus parental inconsistency. The self-view of number 7, I don't know who I am or where I'm going. Identity problems involving gender, career, loyalties, and values. Self-esteem fluctuates with current emotion. 8, the worldview. People are great. No, they're not. Having goals is good. No, it's not. If life doesn't go my way, I can't tolerate it. Therefore, keep all options open. Don't commit to anything. Reverse roles when under attack. Number 9, the self and system perpetuant. Self-defeating coping strategies, particularly reversal, i.e. submissiveness to aggressiveness. more chaos, leading to depersonalization, brief psychotic episodes, increased dysphoria or self-mutilation to achieve relief, reconfirmation of core beliefs, reinforcement of borderline style. Assessment of borderline personality disorder. Several sources of information are useful in establishing a diagnosis and treatment plan for personality disorders. Observation, collateral information, and psychological testing are important adjuncts to the patient's self-report in the clinical interview. This section briefly describes some characteristic observations that the clinician makes and the nature of the rapport likely to develop in initial encounters with specific personality disordered individuals. Characteristic response patterns on various objective and projective tests are also described. For example, MMPI-2 and MCMI-2, and the projective ones, Rorschach and TAT tests. Interviewing patients with borderline personality disorders presents a special challenge because of their instability and ambivalence. Instability or lability is noted in their moods, goals, and rapport with the clinician. Instability regarding rapport is handled by empathically focusing on it. This is done by directing the discussion, keeping the discussion on track, and curbing diversions and outbursts. Asking open-ended questions is preferable to seeking precise answers to closed-ended, pointed questions. Instability is also processed by separating it as a pathological part that needs to be explored. Since it also affects rapport, the clinician must continually acknowledge its presence and effect. The result is that these patients become less defensive and more willing to disclose, thus furthering rapport. Dealing with ambivalence requires confronting their contradictions, while at the same time exhibiting an understanding of their ambivalent feelings. Therapeutic confrontation illustrates their splitting and projective identification and moderates over-idealization or devaluation. It further helps these individuals to realize that their ambivalence results from a perceived lack of support and understanding of their mothers, which they allow to profoundly influence their sense of well-being. It's from Othmer and Othmer, 1989. The Minnesota Multiphasic Personality Inventory, MMPI-2, the Millen Clinical Multi-Axial Inventory, MCMII-2, the Rorschach Psychodiagnostic Test, and the Thematic Apperception Test, TAT, can be useful in diagnosing the borderline personality disorder, as well as the borderline personality style or trait. On the MMPI-2, elevations on scales 2, depression, 4, psychothemia, and 8, schizophrenia, are common. Scales O, social introversion, and K, correction, tend to be high. F, frequency, is typically low. If emotional dysregulation, particularly anger, is prominent, scale 6, paranoia, will be high. Although relatively rare, a 2 to 6 depression paranoia 6 to 2 profile is associated with borderline pathology. Meyer, 1993. On the NCMI-2, elevation on scale C, borderline, is most likely, and a concurrent elevation on scale 8A, passive-aggressive, is also likely. Elevations on such clinical scales as A, anxiety, H, somatoform, N, bipolar, manic, and or D, dysthymia can be expected. Choker, Shane Lee, and Denberg, 1992. On the Rorschach, illogical and fabulized combinations, for example, a horse's head with 2 seahorses growing out of his ears for card 10, are common. Swiasinski, 1985. Such responses are most likely on cards 10.9 and 2. On the TAT, primitive splitting may be noted in characters that are judged as all bad, i.e. devils, in characters wherein only one side of the personality is admitted to or portrayed, or when good-bad characteristics are juxtaposed incongruously. Separation anxiety themes, extreme portrayals of affect and acting out rather than delayed gratification are not uncommon. Belak, 1993. Treatment approaches and interventions. Treatment considerations. Included in the differential diagnosis of the borderline personality disorder are these other Axis 2 personality disorders: passive-aggressive personality disorder, histrionic personality disorder, dependent personality disorder, and the schizotypal personality disorder. The most common Axis 1 syndromes associated with the personality disorder are generalized anxiety disorder, panic disorder, and dysthymia. In addition, other syndromes may be brief reactive psychosis, schizoaffective disorder, hypochondriasis, or the dissociative disorders, especially psychogenic fugue. The borderline personality disorder may be the most common Axis 2 presentation seen in both the public sector and private practice, and it can be among the most difficult and frustrating conditions to treat. Clinical experience suggests that it is important to assess the individual for overall level of functioning and treatment readiness in making decisions about treatment approaches, modalities, and strategies. Individual psychotherapies. Many consider individual psychotherapy to be the cornerstone of treatment for the borderline personality disorder. Although there are widely divergent opinions on the appropriateness or efficacy of the various individual psychotherapeutic approaches, there is consensus on some general principles. Waldinger, 1986, describes 5 points of consensus on treatment of the borderline personality disorder. First, the therapist must be active in identifying, confronting, and directing the patient's behaviors during sessions. Second, a stable treatment environment must be afforded in terms of setting and maintaining limits and boundaries, scheduling payment of fees and role expectations of patient and clinician. Third, connection between the patient's actions and feelings in the present need to be established. Fourth, self-destructive behavior must be made ungratifying. And fifth, careful attention must be paid to counter-transference feelings. Regardless of the specific psychotherapeutic approach utilized, the literature indicates that treatment of the borderline patient is difficult. Countertransference problems are common, and the results are uneven. Gunderson, 1989. Some borderline patients have negative therapeutic reactions, and others experience untoward effects of individual psychotherapy. In some instances, these patients should not be afforded individual treatment. Francis, Clark, and Perry, 1984, offer the no treatment option along with specific criteria for its use. Nevertheless, when treatment is indicated, attention to the patient's needs and expectations for treatment and efforts to match and tailor treatment are essential in maximizing treatment outcomes. This section describes various psychodynamic, cognitive, behavioral, and interpersonal approaches. Psychodynamic psychotherapy. Here is a brief outline of various psychodynamic approaches to the borderline personality. Psychoanalytic psychotherapy, supportive psychotherapy, and short-term dynamic psychotherapy. Psychoanalytic psychotherapy. There are basically two psychoanalytic opinions regarding the treatment of the borderline patients based on the role of early interpretation and the management of negative transference. One view is that confrontation must occur early in the course of treatment, and that interpretation of primitive transference must be made in the here and now situations. The other view is that the early interpretations of the aggressive theme are ineffective and possibly disruptive. Kernberg, 1984, and Masterson, 1976, among others, espouse the first view, whereas Cheswick, 1982, Buey and Adler, 1982, and others advocate the second. Nevertheless, both views agree that personality reconstruction is the goal of treatment, requiring 3 or more sessions a week for a minimum of 4 years. Masterson, 1976, and Masterson and Klein, 1989, have elegantly described the psychotherapeutic process with borderline patients. Supportive psychotherapy is differentiated from reconstructive psychotherapy. The goal of reconstructive psychotherapy is to work through the abandonment depression, feelings of depression, anger and rage, fear, guilt, passivity and helplessness, emptiness and void that follow a recent experience of separation and loss. associated with the original separation, individuation phase. This leads to the achievement of ego autonomy and the transformation of split object relations into whole object relations, and at the split ego into a whole ego. 3 stages of psychotherapy are noted by Masterson. The testing phase, in which the clinician utilizes confrontation or communicative matching to support the patient's emerging individuation as the principal technique. The working through phase and the separation phase. The expected outcome of such treatment is not only reduction in impulsive behavior and other regressive reactions to stressors, but also improved stability in interpersonal relationships. Such personality reconstruction allows the individual to function normally or on a neurotic level. Gunderson, 1989. Supportive psychotherapy. From a dynamic perspective, supportive psychotherapy is less intensive and regressive than is psychoanalytic psychotherapy or psychoanalysis. The goals of supportive therapy with borderline individuals are principally to improve their adaptation to daily life and reduce their self-destructive responses to interpersonal stresses. Kernberg, 1984. The basic techniques of supportive psychotherapy consist of exploring the patient's primitive defenses in the here and now for the purpose of helping them achieve control by non-analytic means and fostering a better adaptation to reality by helping them become more aware of the disorganizing effect of their defensive operations. Manifest and suppressed transferences rather than unconscious and repressed transferences are explored and utilized in order to classify the related interpersonal problems the patient faces. Kernberg, 1984. Such supportive psychotherapy commonly is utilized with moderately and lower functioning borderline outpatients. Typically, sessions are scheduled weekly and may continue for several years. The results of the Menninger outcome study suggests that supportive treatment is able to bring about the basic personality changes that were expected only from reconstructive dynamic psychotherapy. Wallerstein, 1986. So, despite Kernberg's 1984 characterization of supportive psychotherapy as a treatment of last resort, it can be a potent intervention. Klein, 1989, describes the 2 types of supportive treatment for lower functioning borderlines. In the first, confrontative psychotherapy, the treatment process involves confronting resistances that maintain maladaptive behaviors until they become ego-dystonic. A therapeutic alliance takes the place of transference acting out. Treatment also involves the implementation of adaptive modes of dealing with underlying affects, such as new patterns replacing previous self-destructive behaviors and defenses. Unlike reconstructive psychotherapy. This approach does not facilitate the patient's working through abandonment, depression. Its goals are limited to increasing the patient's capacity to work to achieve some consistency in interpersonal relationships. Klein, 1989, also describes an approach to counseling with very low functioning borderline patients. This approach is the treatment of choice for patients with a history of repeated early abuse, neglect or separation trauma, repeated severe psychiatric regressive episodes, or repeated life-threatening, suicidal or homicidal actions. The goal of this treatment is to reduce anger, anxiety, and the depressive affects that persistently interfere with the patient's capacity to function adaptively. The counselor serves as an auxiliary ego for the patient and utilizes a combination of such techniques as reality testing, encouragement, direction, problem solving, and medication. Short-term psychotherapy. Although it was previously assumed that borderline patients were unfit for short-term dynamic psychotherapy, it now appears that short-term and time-limited approaches have some utility with selected patients. In as few as 10 to 20 sessions, treatments can be focused on specific relational or situational problems. And because the focus is so specific, the likelihood of having a regressive transference develop is limited. This approach may be suitable for borderline patients who present with concerns about being engulfed, overwhelmed, or too dependent. It may also be useful for those who have a history of terminating more regressive treatment. Furthermore, it may serve as a springboard for moving into long-term therapy. Klein describes a short-term treatment protocol for borderline patients. Klein, 1989, describes a short-term treatment protocol for borderline patients. The goals are containment, i.e., they come to recognize, control, and contain their propensity to act out. Learning, i.e., that emerging affects that covered their defenses can and must be verbalized rather than acted out. And adaptation, i.e., they channel their energies associated with these affects into adaptive and sublimated behavior and expressions. This short-term approach follows Masterson's model, except that the frequency of sessions is limited and confrontation is the principal technique utilized. Although clarification, interpretation, and communicative matching are sometimes needed. Sessions are scheduled only once or twice a week for a year or less, and day-to-day problems of adaptation and unhealthy defenses are the focus of treatment. Cognitive behavioral approach. According to Beck et al., 1990,
The cognitive therapy approach has significant advantages over other approaches in the treatment of patients with borderline personality disorders. Basically, completion of cognitive therapy is possible in 1.5 to 2.5 years, as compared with psychoanalytically oriented therapies, which typically require 5 to 7 years. Masterson, 1981. Establishing a collaborative working relationship is the very challenging first step in the treatment process, since trust and intimacy are major issues for these individuals. Taking a collaborative, strategic approach based on guided discovery is suggested. Explicitly acknowledging and accepting the individual's difficulty in trusting the therapist, communicating clearly, assertively, and honestly, following through on agreements, and behaving in a consistently trustworthy manner provide the individual with evidence on which trust can be based. Furthermore, setting limits, including specifying a treatment contract, is advised. An initial focus on concrete behavioral goals is useful in reducing the impact of the borderline individual's difficulty with intimacy and trust. Many of these individuals find it less threatening to work on issues for which little introspection is required, and where the focus is on behavior rather than on feelings or thoughts. Not surprisingly, a major focus in cognitive therapy is changing maladaptive schemas. Borderline individuals believe that the world is a dangerous place, that they are helpless, and that they are flawed in a way that inevitably leads to rejection and abandonment by others. It is suggested that these beliefs must be gradually challenged by chipping away at them, by testing expectancies against previous experience, by developing behavioral experiences to test expectancies, and by developing new competencies and coping skills. These individuals must learn to challenge dichotomous thinking, both during and between sessions, as decreased dichotomous thinking often results in decreased mood lability and impulsivity. Behavioral interventions, such as self-instructional training, Meichenbaum, 1977, may be useful in further reducing self-destructive, impulsive behaviors. Non-compliance with treatment is not an uncommon problem with borderline individuals, and often the reason is fear of change. Since they assume the world is dangerous and they have a low tolerance for ambiguity, they find change, including growth, in the course of treatment, threatening. Addressing change openly, examining risks and benefits, planning changes as a series of small steps, and not pressing for change too quickly are recommended. Fear about termination of treatment evoke abandonment and rejection schemas, which must be carefully addressed. In summary, the cognitive therapy of patients with borderline personality disorder begins by developing a collaborative working relationship of trust, and then focuses on modulating moods, impulses, and behavior with cognitive behavioral methods, setting the stage so that such basic schemas as abandonment, defectiveness, incompetence, and mistrust can be modified and changed. In line with Turcat's 1990 formulation that the basic issue for borderlines is problem-solving deficiencies, he proposes a treatment methodology involving several strategies: basic problem-solving training, concept formation training, categorization management, and processing speed management. Interpersonal approach. For Benjamin, 1993, psychotherapeutic interventions with persons with borderline personality disorders can be planned and evaluated in terms of whether they enhance collaboration, facilitate learning about maladaptive patterns and their roots, block these patterns, enhance the will to change, and effectively encourage new patterns. Benjamin offers a number of observations on facilitating collaboration. She insists that therapists offer these individuals a contract for strength building rather than in enabling regression. A collaboration based on strength building must emphasize in sessions as well as in telephone calls or in their clinic lobby that the mutual goal is to build on strengths so that these individuals can pull themselves back together. The collaboration must be against their destructive pattern. Healthy collaboration further requires that transference and countertransference disasters be avoided by setting firm physical and verbal boundaries. Benjamin cautions that the treatment approach she advocates is not appropriate for those who are unable to agree to a contract in strength building. Borderline individuals need to learn to recognize that perceived abandonment sets off a chain of self-destructive patterns. They are likely to relinquish self-mutilation, self-sabotage, and homicidal or suicidal acting out if they can divorce their internalized abusive attachment figures. Essentially, they must give up the desire to be affirmed by these internalized representations. This occurs by developing a dislike of those figures, or by developing a superseding attachment to someone more constructive, such as the clinician. Once these tasks are achieved, the focus of treatment shifts to facilitating new learning. The basic goal is learning how to give and take autonomy while remaining friendly. Benjamin recommends standard treatments for facilitating personal growth. Group therapy. Data on the efficacy of group therapy for the treatment of personality disorders are rather soft. There are many case reports and even a few controlled studies, but no randomized clinical trials, except for the borderline personality disorder, for which there are numerous reports of cases and clinical trials, and even of one randomized clinical trial. Moreover, there is a general consensus that group therapy, under specified conditions, has enormously therapeutic efficacy. This section reviews both dynamic and behavioral group approaches and highlights some representative research studies. The psychodynamic group literature on borderline personality begins in the 1950s. There is general consensus that group dynamic therapy can be a useful adjunct to individual dynamic therapy, but it cannot be the only treatment. Hulse 1958, Slavson 1964, Day and Semrad 1971, Horowitz 1980. Horowitz 1980 cautions that borderline patients require individual psychotherapy to support them throughout group-engendered stress and to integrate the effects the group provokes in them. Furthermore, without individual psychotherapy, premature termination from group therapy is likely. However, Pines, 1975, contends that concurrent, dynamic, individual psychotherapy is not necessary because the group process itself is a potent holding environment capable of containing primitive impulses and projections. Horowitz, 1977, maintains that the individual psychotherapist should not function as a group therapist so as to reduce the possibility of jealousy and fantasies of favoritism among other group members. Most writers on dynamic group therapy for borderlines prefer heterogeneous to homogeneous groups. They insist that borderline patients are more effectively treated in groups consisting of higher functioning individuals with neuroses and other personality disorders. Day and Semrad, 1971, Horowitz, 1977, Stone and Weisman, 1984. There is, however, outcome research that supports the use of homogeneous groups in which all patients have diagnosis of borderline personality disorders. O'Leary, Turner, Gardner et al., 1991. Finn and Shakir, 1990. Lenahan, Armstrong, Suarez et al., 1991. The advantages of dynamic group therapy include dilution of intense transference, Horowitz, 1980, which results from the presence of multiple transferential objects, instead of the single all-encompassing individual clinician. Rage instead is diluted and directed towards other group members. Borderline patients also find it easier to accept feedback and confrontation from group peers than from a therapist. Groups also provide many opportunities to understand and master such borderline defenses as splitting and projective identification. There are some disadvantages and difficulties with group treatment of borderline patients. First, these patients may be easily scapegoated because of their primitive manner of expression. Second, they may feel deprived amid the competition of other group members for the group leader's nurturance. And they may maintain a certain distance in the group because of their privacy attachment to their individual psychotherapist. Gabbard, 1994. Dynamically oriented groups with borderlines tend to span the continuum from ego psychology, O'Leary et al., 1991, Finn and Shakir, 1990, to self-psychology, Harwood, 1992.
Pa 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 pa. Pa 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 ha ha ha. Okay, about to start with after Harwood, 1992. We are on page 72. Starting after self-psychology, Harwood, 1992. Behavioral group therapies for borderline patients focus less on underlying explanations for the symptomatic behavior and more on helping the patients acquire the specific skills necessary to control their affects, reduce their cognitive distortions and projective identifications, and find alternatives to self-destructive behaviors. Linehan, 1983, 1987, 1993, provides a manual guided strategy for the treatment of self-destructive behavior and impulsivity called Dialectical Behavior Therapy, geared primarily to chronically parasuicidal borderline women patients. The treatment strategies and interventions have applicability to more highly functioning individuals. The group session employs didactic skill training and behavioral rehearsal techniques directed at dependency and other interpersonal patterns, as well as at improving affect tolerance. These twice-weekly sessions for 1 year are complemented with weekly individual counseling. There has been some noteworthy research with borderlines in group treatment that will be briefly highlighted. Nels, 1991, and Nels and Diamond, 1993, report process and outcome data on group therapy of borderline patients in a homogeneous treatment format. The group was highly structured, although group members defined their own treatment goals. Patient outcomes included decreased depression and hostility, which was associated largely with 2 interventions: providing and seeking information. Dick and Woof, 1986, reported data on a time-limited dynamic group therapy with heterogeneous groups containing a number of borderline patients. The group met daily for 12 weeks. A 1-year follow-up showed an 82%
reduction in the use of psychiatric services as compared with a control group of untreated patients, and a 3-year follow-up showed that the gains had been maintained. Finally, Linehan et al. 1991 report the only randomized clinical trial to date, parasuicidal female borderline patients were randomly assigned to dialectical behavior therapy groups or traditional community treatment for a 1-year period. Those in behavioral groups had fewer incidents of parasuicide, were more likely to remain in individual therapy, and had fewer inpatient psychiatric days than did those in traditional treatment. A manual guided approach called Relationship Management Psychotherapy is a time-limited group approach that is being compared with open-ended individual dynamic psychotherapy in a randomized clinical trial. The study is still in progress, but preliminary results are encouraging. Clarkin, Marzaliali, and Munro Bloom, 1991. Marital family therapy. Families of borderline patients often exhibit severe pathology, which may be of etiological significance. Borderline patients' parents have a high incidence of affective disorders, alcoholism, antisocial personality disorder, and borderline personality disorder or traits. The parental relationship is usually characterized by neglect and overprotectiveness. Family therapy can be useful and in some instances is necessary in maintaining borderline patients in outpatient psychotherapy. This is particularly the case when borderline patients remain financially or emotionally dependent on their parents. Family therapy with borderlines have been developed along at least 3 theoretical lines. The first is the psychodynamic, particularly in terms of object relations and systems theory. Everett, Halperin, Volgi, and Whistler, 1989, present the most complete discussion of this approach in their book, Treating the Borderline Family, a Systemic Approach. They specify 5 treatment goals: increasing the family's ability to reduce the systemic splitting process, increasing family members' capacities for owning split-off objects, and moving toward interacting with others as a whole person, reducing oppositional and stereotypic behavior of all family members, resetting external boundaries for both unclear and intergenerational systems, resetting internal boundaries for spousal, parent-child, and sibling subtypes, permitting a clearer alliance between the parents and limiting reciprocal intrusiveness of children and parents. 5 treatment strategies for accomplishing these goals in an outpatient family treatment setting are development and maintenance of a therapeutic structure, reality testing in the family, interactional disengagement, intervention in the intergenerational system, and solidification of the marital alliance and sibling subsystem. Another treatment orientation is the structural family approach developed by Minuchin, 1974, Shane and Koval, 1988, described severe borderline pathology in terms of a spouse subsystem that is internally over-involved and contemporarily distant and disengaged from the old subsystem. In effect, borderline women have a systems equivalent of object splitting, wherein family subsystems are organized around dichotomous extremes: collusion and sabotage, loyalty and scapegoating, inclusion and rejection, nurturance and neglect, and symbiosis and abandonment. It is this structural pattern of family interaction that is the focus of systemic change. Rakkhita, 1992, provides an extensive discussion of an integrated object relations and self-psychology approach to the marital treatment of the borderline patient. She presents a detailed treatment protocol and several case reports that illustrate this method. A third option is the relationship enhancement therapy approach for borderline families and couples. Relationship enhancement, developed by Gurney, 1977, integrates social skills training, psychodynamic principles, and interpersonal therapy techniques. Since borderline patients have major deficits in self-differentiation and communication, the relationship enhancements focus on skill building in some areas seems promising within couple and family settings, particularly for mild to moderately dysfunctional borderline patients. Waldo and Harmon, 1993. The clinician functions largely as a coach to develop the necessary relational skills, usually in 2-hour sessions. Waldo and Harmon report a case of time-limited intervention that was successful. A 12-month follow-up showed that the changes had been maintained. Medication. A full gamut of psychotropic medications have been employed in the treatment of borderline patients, including low-dose antipsychotics, tricyclic antidepressants, anticonvulsants, and most recently, selective serotonin reuptake inhibitors. Given that the diagnosis of borderline personality disorder encompasses a heterogeneous group of patients, often with intractable symptoms, both clinicians and patients have held high and even magical expectations for medication as a cure, or the very least as a palliative. Not surprisingly, the pharmacological treatment of borderline pathology can be difficult and frustrating for both clinician and patient. The basic treatment strategy has been to match a medication to specific target symptoms. Recent pharmacological and neurobiological research suggests that the borderline disorder encompasses 3 clusters of symptoms: affective instability, impulsive aggressivity, and transient psychotic phenomena. Kokaro and Kavusi, 1991. It appears that affective instability is related to brain abnormalities in adrenergic and cholinergic systems. It has been shown that such agents as lithium carbonate and carbamazepine are effective in modulating effects. Abnormalities in central nervous system serotonergic function, resulting in impulsivity, seem to respond to serotonergic agents such as fluoxetine, Prozac. Finally, abnormalities in central dopaminergic systems may account for transient psychotic systems. Thus, low-dose antipsychotics have been shown to be effective with this symptom cluster. The possible efficacy of serotonin reuptake inhibitors, specifically with borderline pathology, such as dysphoria and impulsive aggressive behavior, has been the subject of a number of clinical trials. Fluoxetine, Prozac, appears to be effective in treating symptoms related to depressed mood and impulsive aggressivity. Coccaro, 1993. Markowitz, Collerbreeze, Schultz, and Meltzer, 1991, report similar results in a prospective, non-blinded study. Double-blind, placebo-controlled trials should help confirm the efficacy of this class of medication for borderline pathology. However, there are some potential complications or disadvantages with pharmacotherapy in the treatment of borderline patients. First is the matter of non-compliance, related either to side effects or to secondary gain. Medications can serve as a leverage to control the prescribing clinician or other caregivers. Demands for frequent changes in the dope or type of medication, overdosing, and failure to take the medication as it was prescribed are ways of transference, acting out. Second, although borderline patients may appear to others to have improved while on medication, they may report that they feel worse, or vice versa. Gunderson, 1989, suggests that this apparent paradox may come about if the patient believes that symptomatic improvement will result in undesirable consequences, such as loss or abandonment or dependent gratifications. Perhaps the most clinically useful contribution to the literature is that by Klein, 1989, who skillfully describes the integration of pharmacotherapy into an individual psychotherapy context. He, Klein, provides 3 guidelines for the effective utilization of medication: careful attention to diagnostic precision, evaluation of objective signs rather than subjective symptoms when determining when and which medication to use, and controlled awareness of the risks of therapeutic medication. 7 case histories illustrate these guidelines. Klein's chapter should be required reading for both medical and non-medical clinicians involved in the treatment of borderline patients. Combined and integrated treatment approaches. There is considerable consensus that combined treatment is essential, or at least preferable, for borderline pathology, given its severity and apparent treatment resistance. Clearly, differences exist between the prognosis and treatability of the highly functioning borderline, i.e. GAF over 65, and the low functioning borderline, i.e. GAF below 45. Treatment success using only traditional individual psychoanalytic psychotherapy may be possible with the highest functioning borderline individual, but is not likely with the lower functioning patients. In line with the basic premise of this book, the lower the patient's functioning, motivation, and readiness for treatment, the more that treatment must be integrated and combined. The most common recommendations for combined treatment is to prescribe both individual therapy and group therapy. There is currently no consensus on which theoretical approaches to combine or whether they should be combined or sequenced. The earliest recommendations for combined treatment was Tachbachnik, 1965, who advocated concurrent dynamic individual psychotherapy and dynamic group therapy. Horowitz, 1980, however, advocates sequencing dynamic group and individual therapy, in which the group experience prepares the patient to utilize individual therapy productively. Clarkin et al. 1991 also recommend combined individual and group modalities, but favor individual behavior treatment with long-term manual-guided group treatment. Others recommend combining individual therapy and family therapy, including Kernberg, 1984, who prescribes the indications for concurrent as well as sequential utilization of these modalities. Berger, 1987, recommends combined psychotherapy and pharmacotherapy because these individuals are difficult to treat with only one modality. He notes that combined treatment can be complicated by the borderline's tendency to idealize one treatment and negate the other. Koenigsberg, 1993, offers a very thoughtful review of combining medications and psychotherapy, highlighting the indications for and contraindications to this treatment decision. He also describes the complications inherent in combined treatment strategy, but adds that these can be addressed by special structuring of treatment, attention to counter-transference issues, and vigilance for splitting. Koenigsberg contends that combining medication and psychotherapy has considerable value for seriously symptomatic patients, those prone to treatment non-compliance, or those who are likely to undergo intractable affective storms and psychotic regression. Lazarus, 1985, the developer of multimodal therapy, endorses the combined use of several modalities concurrently or sequentially for a variety of difficult patients, including borderline individuals. Vakani, 1989, describes treating the alcohol-abusing borderline personality with psychotherapy, family therapy, group therapy, and attendance at Alcoholics Anonymous meetings. Nels and Diamond, 1993, described the modalities for lower functioning borderlines in a community-based setting. These modalities, which are coordinated and continuous, include individual therapy, group therapy, medication, drug and alcohol services, psychosocial rehabilitation, crisis intervention, and use of crisis houses. So that's the end of chapter 4, the borderline personality disorder, Len Sperry, MD, Ph.D. So I hope this has been useful. Its primary function is for me to get more familiar with previous research and writings on the subject of the personality disorders. One function is that it's going to help me to consolidate my knowledge. I appreciate that it comes from the 1990s, because since then we've had other research, which I will be going on to study and also to make videos on. It takes us back to DSM-IV perspectives. I would be also interested to look at DSM-III writings, DSM-II writings, and DSM-I writings to track the history and progression of the understanding, perspectives, treatments, and analyses of the different personality disorders. I am deeply grateful to Dr. Len Sperry for his work in this research and this compilation, this guidebook. Again, I make no claims to be a qualified licensed health professional. I do hold a diploma in Buddhist psychotherapy. I have experience of approximately 7,000 meditation retreat interviews. I gained these during the 1980s. We had an average of 15 meditators resident at the Wat Rampung Meditation Center, where I was assistant to Lungpo Banyat, the primary meditation teacher. I have traveled over approximately 160 Buddhist temples over Asia. During my time, I have met a number of people who fit the diagnostic category of traits which match borderline personality disorder. I'm not qualified to diagnose anyone personally, but the experiences I gained during the time of working with them, getting to know them, befriending their families, even living together with the family, has given me great cause for interest in this subject, including suicide of one person, for example. So I am deeply interested in understanding this disorder deeper and the other personalities deeper. I'm also interested in current contemporary modern treatments, and also if there are bridges that can be made or resources taken from the ancient Buddhist teachings which can assist in gaining insights two-way, that the modern studies throw light onto the Buddha's teachings in the early Buddhist teachings, early Buddhist schools, and the texts that we have. And if there are things that we can derive from the Tipitaka, the early experiences, the sub-commentaries and the commentaries, which can throw light on treatments and insights that could be used in the modern day setting. This is Bhante van Rakkhita, Samanera, also known as Brother Ben, signing off. I hope this video has been useful. Please leave your comments underneath, and we look forward to more of the studies of personality disorders. And in the future, we shall also be making more videos about the bridging to the Dharma, the Buddha's teachings, and the comparisons and contrasts that we find there. May many beings be free from suffering.